Indications for mechanical ventilation. This is Chapter 19 of oxygen delivery, which during mechanical ventilation, you need to maintain a patent airway and adequate oxygen saturation of 95% or greater. Potential diagnoses for mechanical ventilation would include hypoxemia, hypoventilation with respiratory acidosis, airway trauma, exacerbation of COPD, acute pulmonary edema due to myocardial infarction or heart failure, asthma attack, head injury, cerebrovascular accident or coma, neurological disorders such as multiple sclerosis, myasthenia gravis, and Guillain-Barré, obstructive sleep apnea, respiratory support following surgery to decrease workload, and respiratory support while under general anesthesia or heavy sedation. Common modes of ventilation, adjunctive therapy, and weaning modalities. Modes of ventilation. Assist control AC is a preset rate and tidal volume where the client initiates breath and ventilator takes over for the intubated client. Hyperventilation can result in respiratory alkalosis. Client can require sedation to decrease the respiratory rate. In SIMV, synchronized intermittent mandatory ventilation, it's a preset rate and tidal volume for machine breaths. Client initiates breath and tidal volume will depend upon the client's effort. Ventilator-initiated breaths are synchronized to reduce competition between ventilator and client. It's used as a regular mode of ventilation or a weaning mode rate decrease to allow more spontaneous ventilation for the intubated client. It can increase work of breathing, causing respiratory muscle fatigue. IRV, inverse radial ventilation, lengthens inspiratory phase to maximize oxygenation in the intubated client. It's used for hypoxemia refractory to PEEP, P-E-E-P. It's uncomfortable for clients and requires sedation and or a neuromuscular blocking agent. High risk of volute trauma and decreased cardiac output due to air trapping with IRV. Now moving on to APRV, which is airway pressure release ventilation. This allows alveolar gas to be expelled by the lungs' own natural recoil. It's time triggered and pressure limited. Breaths can be initiated spontaneously or by the ventilator. It causes less ventilator-induced lung injury and fewer adverse effects on the cardiovascular system. Independent lung ventilation, ILV, is a double lumen ET tube that allows ventilation of each lung separately. It's used for clients who have unilateral lung disease. It requires 2 ventilators, sedation, and or use of a neuromuscular blocking agent. High-frequency ventilation delivers small amount of gas at rates of 60 to 3,000 cycles per minute. High-frequency ventilation often is used in children. Client must be sedated and or receiving neuromuscular blocking agents. Breath sounds are difficult to assess with this high-frequency ventilation. Adjunctive therapy, which is PEEP, positive end expiratory pressure, is a preset pressure delivered during expiration. It's added to prescribed ventilator settings to treat persistent hypoxemia. It improves oxygenation by enhancing gas exchange and preventing atelectasis. The amount of PEEP, positive end expiratory pressure, is added, which is typically 5 to 15 centimeters H2O. Moving on to weaning modalities. There's pressure support ventilation, which is PSV. It works to keep the alveoli from collapsing during expiration. It allows for greater oxygenation and makes the work of breathing easier. It allows for lower levels of FiO2 to be used. It can be used with IMV, which is... we don't have IMV listed here. It does not look like intermittent mandatory ventilation. Or AC modes, which would be the assist control AC. It can be used with IMV or AC modes to treat or prevent atelectasis. The setting is 5 to 20 centimeters H2O. Greater than 20 centimeters H2O can cause lung damage. Continuous positive airway pressure is another weaning modality, CPAP. It's a positive pressure supplied during spontaneous breathing. No ventilator breaths are delivered unless in conjunction with SIMV, which is the synchronized intermittent mandatory ventilation, SIMV. The risks with CPAP include volume trauma, decreased cardiac output, and ICP, intracranial pressure. Considerations with mechanical ventilation is preparing the client. You need to explain the procedure to the client and establish a method for client to communicate, such as asking yes or no questions and providing written materials using a dry erase and/or picture communication board or lip reading. Ongoing care for the patient would be maintaining a patent airway, assessing the position and placement of the tube, documenting tube placement in centimeters at the client's teeth or lips. Use 2 staff members for repositioning and resecuring the tube. Apply protective barriers such as soft wrist restraints according to hospital protocol to prevent self-extubation. Use caution when moving the client. Also, suction oral and tracheal secretions to maintain tube patency. Support ventilator tubing to prevent mucosal erosion and displacement. Have a resuscitation bag with a face mask available at the bedside at all times in case of ventilator malfunction or accidental extubation. Assess respiratory status every 1 to 2 hours. Breath sounds equal bilaterally. Presence of reduced or absent breath sounds. Respiratory effort or spontaneous breaths. Suction the tracheal tube to clear secretions from the airway. Monitor and document ventilator settings hourly. Rate, FiO2, and tidal volume. Mode of ventilation, use of adjuncts, PEEP, CPAP, plateau or peak inspiratory pressure, PIP, alarm settings, and monitor ventilator alarms, which signal if the client is not receiving the correct ventilation. Never turn off ventilator alarms. And there are 3 types of ventilator alarms. There's volume, low pressure alarms, which indicate a low exhaled volume due to disconnection, cuff leak, and/or tube displacement. There's pressure, high pressure alarms, which indicate excess secretions, client biting the tubing, kinks in the tubing, client coughing, and pulmonary edema, bronchospasm, or pneumothorax. Apnea alarms indicate that the ventilator does not detect spontaneous respiration in a present time period. Maintain adequate but not excessive volume in the cuff of the endotracheal tube. Assess the cuff pressure at least every 8 hours and maintain the cuff pressure below 20 mmHg or 20 to 30 centimeters H2O to reduce the risk of tracheal necrosis. Assess for an air leak around the cuff. Client speaking, air hissing, or decreasing SaO2 could indicate a leak in the cuff. Inadequate cuff pressure can result in inadequate oxygenation and/or accidental extubation. Administer medications as prescribed, such as analgesics, morphine and fentanyl, sedatives, propofol, diazepam, lorazepam, midazolam, and haloperidol. Clients receiving mechanical ventilation can require sedation or paralytic agents to prevent competition between extrinsic and intrinsic breathing and the resulting effects of hyperventilation. Neuromuscular blocking agents such as pancuronium, atracuronium, and vecuronium are infrequently used in the clinical setting due to their long half-life. Neuromuscular blocking agents paralyze muscles but do not sedate or relieve pain. So they just are used to paralyze muscles. The use of a sedative or analgesic agent in conjunction with neuromuscular blocking agent is typically prescribed. Also preventing agents such as famotidine or lansoprazole, antibiotics for established infections. Reposition the oral endotracheal tube every 24 hours or according to protocol. Assess for skin breakdown. And with older adult clients, have fragile skin and are more prone to skin and mucous membrane breakdown, so be aware. Also with older adult clients, they have decreased oral secretions. They require frequent, gentle skin and oral care. Provide adequate nutrition. assess GI functioning every 8 hours, monitor bowel habits, administer enteral or parenteral feedings as prescribed. Continually monitor the client during the weaning process and watch for signs of weaning intolerance. Respirations greater than 30 per minute or less than 8 per minute would be abnormal. Blood pressure or heart rate changes more than 20% of baseline, SaO2 of less than 90%, dysrhythmias, elevated ST segment, significant decrease in tidal volume, labored respirations, increased use of accessory muscles and diaphoresis, restlessness, anxiety, and decreased level of consciousness. Have a manual resuscitation bag with a face mask and oxygen readily available at the client's bedside. Have reintubation equipment at bedside. Suction the oropharynx and trachea. Deflate the cuff on endotracheal tube and remove the tube during peak inspiration. Following extubation, monitor for signs of respiratory distress or airway obstruction, ineffective cough, dyspnea, stridor. Also assess SpO2 and vital signs every 5 minutes. Encourage coughing, deep breathing, and use of incentive spirometer. Reposition the client to promote mobility of secretions. Older adult clients have decreased respiratory muscle strength and chest wall compliance, which makes them more susceptible to aspiration, atelectasis, collapsed lungs, and pulmonary infections. Older adult clients require more frequent position changes to promote mobility of secretions. Complications that can occur is trauma, such as barotrauma, which is damage to the lungs by positive pressure, which can occur due to pneumothorax, subcutaneous emphysema, or pneumomediastinum. Volume trauma is damage to the lungs by volume delivered from one lung to the other. Fluid retention is another possible complication. Fluid retention in clients who are receiving mechanical ventilation is due to decreased cardiac output, activation of the renin-angiotensin-aldosterone system, and or ventilator humidification. Nursing actions include monitoring INO, weight, breath sounds, and endotracheal secretions. With